Module 2B. Cognitive behavior therapy works best for most people when patients are encouraged to move gradually from simplest, least threatening step to the more complex threatening step. For example, with a fear of flying, we would have the patient gradually expose herself to imaginal feared images, then live feared images. Say, gradually imagining being in an airport or airplane to eventually going to an airport and then on a real flight. Cognitive behavior therapy can be a relatively brief talk therapy, partly due to between-session homework and practice, which is encouraged. Our goal is to help the patients become their own therapist by applying practical skills to reduce problematic symptoms. It's a good idea to orient patients to the idea of between-session practice or homework. Some helpful points to communicate to the patient if he is not totally on board with potential benefits of practicing skills include practicing skills can help make them stick better. Practicing helps the patient become more of an active participant in the changes that they choose to make. Practicing skills can also include self-monitoring and can help you adopt a curious attitude about what works for you and what doesn't. Also, research has shown that those who practice skills between sessions have better treatment outcomes. Cognitive behavior therapy is a collaborative treatment approach. The stronger the patient-therapist relationship, which is fostered by collaboration together, the more effective the therapy. The therapeutic alliance is facilitated by the patient's level of trust that is fostered by the therapist's reflective listening skills, empathy, respectfulness, and technical expertise. Collaboration is also promoted by establishing an agenda at the beginning of each session, providing and requesting feedback throughout the course of each session, using Socratic questioning, guided discovery, and joint goal setting, and assigning between-session homework. The following video clip is an example of agenda setting in a formulation-driven session. We will see a 45-year-old married white male with a long-standing history of depression and obsessive-compulsive disorder. The theme of this session relates to a recent stressor of a failing business and marital distress. The patient has demonstrated a tendency to wallow in depression and dysfunction. So, Steve, let's check in for our session today, if we could.
Okay. Feeling like everything's falling apart. My business is just really rocky. My marriage is collapsing.
Okay.
I just feel like I'm not able to really deal with anything right now. It's just all kind of imploding.
There's a lot of things, it seems like. Yeah.
Yeah.
So one of the things we've always done is try to set a practical agenda for our session. There's a lot of things going on, but we've always worked on pausing and taking a look at the big picture and then seeing what's most pressing. How does that sound?
That sounds good.
Okay, so can we do that? Can we figure out what's the most pressing issue and put that on our agenda?
Sure. I mean, business, the financials, we just had, our quarterly report, and so that was very much at the forefront of my activity over the last couple of weeks, and it's just been really taking over my thoughts, both at home and at work.
Okay. Do you think you're thinking realistically and reasonably about work issues, or do you think you're going overboard with the concerns?
Well, I think that there's a legitimate concern in this, economic environment, but I think it's starting to take over. I think I'm going overboard.
Okay. Any specific worried thoughts that you're having?
Well, that the business is going to go under and it's going to be my fault.
Oh, okay. All right. And then any kind of behaviors you're engaging in to try to relieve your anxiety?
Well, I've been just checking and rechecking all the financials, the spreadsheets. They get updated every half hour. And so I've been just having them up on my computer and just constantly waiting for them to come in, the updated financials, and then at night I just scour through everything and see what's, maybe where we can cut a little expenditures. And
So does this seem like you're doing it a reasonable number of times, this checking and rechecking, or do you think this is kind of in the category of more compulsive and doing it too much?
Well, when I'm doing it, it doesn't seem like it's too much, but...
Do you think other people do it to the same level?
No. I don't think so, no.
Okay. And when you're rechecking, is it stuff that's that changes much?
No, I mean, that's the problem. I think I just go through all the same stuff over and over again.
Okay. So it almost sounds like we're dealing with two things here that we could put on our agenda. One would be looking at that really severely worried thought of my business is going to go under.
Yeah.
And then the other part would be the more of the obsessive compulsive things that you've been doing in the past and we actually worked on for homework this week.
Yeah.
So why don't we set that as our agenda? That probably will take our full session up.
Okay, that sounds good.
Great. Setting an agenda at the beginning of each session is not always an easy task, but definitely makes a session more productive. For example, you can begin a session with an invitation such as, let's set an agenda to make sure we follow up on our homework and figure out how to spend our time most productively. The patient and therapist can collaboratively generate and then prioritize agenda items. It is unlikely that more than 2 or 3 items, including homework review and medication review, can be discussed within a 50-minute session. Always review the homework first, unless a patient presents with a crisis agenda item like suicidality. This makes sense as other important issues or barriers to intervention effectiveness may come to light. And if this occurs, it's fine to modify the agenda. Agenda setting should take no more than 5 to 10 minutes. In your initial or second session, explicitly orient the patient to the rationale and structure of agenda setting. But even with your best efforts to structure your agenda, patients may still launch into a full discussion. It is wise to say something like, "Let me stop you for a second. I think it would be helpful to lay out our plan for the session and then focus on the details." Help the patient put the topic or issue into a nutshell or summary statement. This will limit the likelihood that agenda setting time becomes meandering without a clear direction. For example, say, "Okay, this sounds like another example of when you feel inadequate. Should we put that on our agenda to explore? Is there anything else you would like to make sure that we cover?" Be realistic about what can be accomplished in the session. The therapist should take an active role in setting a realistic, time-managed session. Remember that in a 45 to 50-minute session, it makes sense to spend 5 to 10 minutes setting the agenda, then some time to review the homework, and then address 1 or 2 additional, perhaps related issues. Leave 10 to 15 minutes for review and homework assignment. A session goes by fast, and you want to maximize what can be accomplished. My philosophy is that less is more in a session. I would rather a patient leave a session with 1 additional skill or understanding about themselves than overwhelm them with too much information. This is another video clip of a session with a patient who would like to launch into a session without setting an agenda. So hi Jenny, we meet again, and as we usually do, how about if we start off our session with setting an agenda, making sure we talk about all the things that are most pressing to you, and then also follow up on our homework.
Okay. Well, I have to admit I have not felt this way in a long time. I was really nervous about coming in here today, and I'm pretty sure I know where it's coming from. I mean, remember when I was telling you about...
Right, right. Could we sort of extract what the agenda item really is and maybe look at what's behind that anxiety?
Well, I think it all has to do with me not really wanting to get better.
Okay. All right, so that's that general theme that we've been talking about of not necessarily feeling comfortable losing the attention of others and also the love of others.
Yeah, I still think it just all goes back to what I was telling you about my mother.
Okay, all right. So before we get to that, though, because I do think that's a really important agenda item, how about if we also see if there's anything else pressing?
Okay.
Is
I think that's the most...
That's the most pressing?
Yeah,
okay.
that's definitely it.
And then also maybe we can carve out some time to discuss the homework that we worked on last week, and hopefully we can both be mindful of the time so we get to both items on our agenda.
Okay.
Make sure to check in with patients about the content and process of the session. For example, you could say, "I notice that you are quiet and I am wondering what you were just thinking. How does this plan sound to you? Does it seem like I am understanding what you are saying? Could we discuss what was helpful or not so helpful about today's session?" It's very useful to summarize what has been discussed and clarify homework at the end of the session to ensure that the patient and therapist are on the same page. We will now watch a video clip of a 50-year-old married white female with long-standing depression, anxiety, and a spider phobia. She presents to this session with increased depressed mood and anhedonia. As you watch, pay attention to how the homework assignment is a direct outcome of difficulties discussed. All right, so you've been saying that you're feeling a lot more depressed, a lot more anxious, and that you're also having a tendency to do less things, do less activities, especially going out with your friends and doing tasks and chores. What's happening?
No, just the days just pass. I just lie on the couch or just playing mindless video games.
You don't feel like doing anything, so then you don't.
Right.
Okay. And when you do lie around a lot, what tends to happen with your energy level?
Oh, well, it's rotten. It feels worse. I feel like I can't do anything.
Yeah. So, do you think that's really true, that you can't do anything?
It feels like it.
Yeah. Feels like you can't. Let's talk about that statement if we could.
Okay.
You say it feels like you can. Does it feel possible, not possible?
It just feels like I can't even get up.
Okay. Remember when you were struggling with the spider phobia and you also didn't think that you would be able to approach
Yeah.
moving in the direction of even looking at a spider? Do you remember that? And we gradually set up a plan for you to move closer to the spider. But remember how that felt?
Yeah. Yep.
Okay. Remember how scared you were?
Yeah, I do.
Right. Now, how did you manage to get through those exposures, those movements towards the spider, even with the anxiety?
Well, I made a plan.
Mm-hmm.
So I just tried to do things a little at a time.
Yeah. And then what gradually happened?
It got better.
Yeah. You think your anxiety gradually changed, went down?
Yeah, lessened, yeah.
Yeah. What would you imagine would happen with regard to the depression if you were to take small steps?
Yeah, maybe I could try it. Maybe I could make a plan, like an activity plan.
Yeah. Yeah. And what kinds of little things might you put on that activity plan to get started?
Well, maybe doing the dishes.
Doing dishes, that would be good to get started with doing one small thing.
Mm-hmm.
And maybe we can continue brainstorming a little bit about what you could put on your activity schedule.
Okay.
Okay. Once you get started, by the way,
What would you imagine would happen with your mood, your depression, say? If you were able to accomplish a few small things.
It would feel good if I got something done.
Yeah. You think your mood might shift some?
Yeah. Yeah.
Okay. So worth a try?
Yeah. Yeah.
Okay.
Collaborative empiricism takes place when therapist and patient scratch their collective heads and embark on a journey of jointly researching and testing out which cognitions and behaviors are accurate and helpful and which are not. We are encouraging our patients to adopt a curious, more objective mind. Patients are more likely to make changes in their thinking and behavior patterns when they are guided to test hypotheses on their own. The process of guided discovery can be achieved by fostering a socratic dialogue between the patient and therapist. Patients are asked easily answerable questions that can lead to recognizing for themselves patterns of dysfunctional thinking or maladaptive behaviors. The following video clip involves a session with a married 45-year-old struggling in his marriage. He reports feeling disconnected and distant from his wife. In this session, we begin to explore the patient's role in his problem. The therapist asks a series of questions to help the patient explore the nature of his influencing core beliefs. The goal is to help him gain more awareness of his unhelpful core beliefs and then begin to challenge them on a cognitive level and begin to experiment with behavioral changes, which may also help shift his core beliefs. So we've been talking about your relationship with your wife, and you've been saying that it's been hard for you to have a conversation with her, and we had set that as a plan for the week, that you would try to initiate a conversation with the goal of trying to feel a little closer to her, a little more intimate. How did that go?
Well, I didn't do it. It just didn't feel right.
Okay, can you say more?
Well, I was just, I don't know, I felt worried. It just felt strange.
Okay. Any specific worries that you could identify?
Well, I thought that she might want more.
More?
She might want more of, like, once we talked, that she'd want more from me. You know, she'd find out more about me.
Oh, and what would be so bad about that?
Well, she might not like me.
Okay. And if she didn't like you?
Well, if she didn't like me, then she'd, I don't know, she might leave. She might, like, the things she finds out about me might cause her to see that I'm not really the person that that she thought she was with, and then she would end up being not like me, and
then you'd be alone.
And then I'd be alone. She'd leave.
Okay. Yeah.
That's not.
Looks like you have a lot of feelings about that idea, that prospect.
It's scary.
Right. So what I'm thinking is maybe there's something here. Maybe we should explore this a little bit more, because it seems like this barrier that seems to stand between you and feeling close to people. We might be onto something that's related to that. And if we could explore it a little more, that might be useful.
Yeah, there's definitely something here.
Okay. There are many ways to foster a patient's self-discovery of problematic issues. Asking gentle, leading, Socratic questions aimed at helping a patient come up with alternative ideas can be a very powerful clinical skill. The following are examples of Socratic questions. What evidence is there to support what you are saying? How might this assumption be refuted? how might you begin to feel more comfortable? Another way of looking at this is, does this seem reasonable? What could be a plan for discovering if this belief is true or faulty? It is essential that therapist and patient collaboratively establish a treatment plan with specifically defined targets for change. An example of a specific target for change could be 50% reduction in frequency of panic attacks as determined by the panic attack self-monitoring record. If goals for treatment are too broad or too vague, it is difficult to establish a helpful plan, and it is difficult to measure changes over time. Decisions about treatment strategies and pacing should be based on the individual case formulation, the patient's readiness to change, the patient's motivation level, and willingness to be an active participant in their own treatment. If the patient is ready to be an active participant and is willing to complete between-session homework or practice skills, then there are ways to make sure that homework is maximally effective and helpful. First, make sure the patient understands the rationale for homework and agrees to do the assignment. It can also be helpful and compliance enhancing to ask the patient to suggest their own homework or have input into the plan for homework. It's helpful to be specific and concrete in planning homework, including details about when, where, and with whom, how long, or a backup plan if Plan A does not work out. Always connect the assignment to the work already in progress in the session and the overall treatment plan. Make sure to practice and review the homework plan in the session. This will help optimize the likelihood that the patient will work on the homework and will help troubleshoot potential barriers to between-session homework completion. Always anticipate and discuss obstacles which may prevent the patient from completing or even attempting the assignment. Make sure to ask, is there anything that could stand in your way of carrying out this assignment? It can also be very helpful to ask the patient, what is the probability that he or she will do the assignment? If the response is anything less than 100%, discuss what the obstacles are. The obstacles could include sabotaging thoughts like, why bother? Lack of understanding of the purpose of the assignment, or lack of understanding of the task itself. Sometimes a barrier could be the patient's resentment expressed in the thought, why should I even have to do this? It is very helpful to address barriers before sending the patient home to complete the task. If the patient returns to the next session without completing or attempting homework, assess all of the possible barriers mentioned above.